So welcome to session 4A. It's entitled Meet the Clinical Trialist. Our first speaker is Dr. Amar Krishnaswamy. He is the section head of invasive and interventional cardiology here in the Department of Cardiovascular Medicine at the Cleveland Clinic.
Hi, thank you so much. And good afternoon, everybody. Thank you for being here. Thanks to Amanda and the Heart Failure Group for this tremendous agenda they've put together, and my honor to be part of it. I have no financial disclosures. So in truth, this is not going to be a talk that focuses on a tremendous amount of data. I think that interventional cardiology sort of grows in leaps and bounds annually. And so I'd like to just provide sort of understanding for you guys of what can we offer to the patients that are generally taken care of by the Heart Failure Group, specifically with regard to secondary mitral valve regurgitation and also, of course, tricuspid valve regurgitation. So when we get to, with SMR, of course, the cornerstone of therapy beyond, of course, the heart failure GDMT is transcatheter edge-to-edge repair, or TEER. And I'm not going to belabor this data, but despite the fact that this 5-year outcomes of the COAPT trial, which randomized patients between GDMT and TEER, with FMR showed substantial and statistically significant benefit to both heart failure hospitalization and functional outcomes, as well as mortality. We are still, essentially almost 10 years out from the initial publication of this trial, sort of giving talks about why TEER is good in the FMR population. So I think it's really important to understand that even the long-term, or if you want to call 5 years, midterm data from COAPT demonstrates this benefit. I would also point out, and it's not on this slide, but I'd point out that when you look at the 5-year outcomes and you go through the supplemental tables, you see that actually less than 50% of these patients are able to tolerate the pillars of GDMT, whether it's due to hypotension, whether it's due to kidney disease, all of the things that you face on a regular basis. And so I think it's important to keep in mind that following these patients sort of longitudinally is really important. I would just state for the record, again, the guidelines from all of the major societies do provide a Class 2A recommendation. There's a push to increase this to 1, but a Class 2A recommendation for TEER in the patients with functional or secondary mitral valve regurgitation. Surgery is considered a Class 2B indication. This is something really should be reserved for patients who have other concomitant diseases that require surgical therapy. Here's an example. This is a 62-year-old with severe secondary mitral regurgitation, as you can see here in the echocardiogram, blunted and reversed pulmonary vein systolic flow, a mean LA pressure of 28 with V waves of 65. We're quite thorough when we bring these patients to the OR for TEER therapies, just to make sure we're giving them the best possible result. You can see here after 3 clips, really sort of a trivial degree of regurgitation, especially compared to the pre-above. Normal pulmonary vein flow on the echocardiograms. And you can see here V waves down to about 25, still mildly elevated LA pressure, but again, this is where the GDMT and continued heart failure follow-up is relevant. This is a bit more an extreme case. A gentleman with actually had been discharged from the hospital on optimized GDMT, but unfortunately within 2 weeks returned really in decompensated heart failure and cardiogenic shock as gauged by the PA catheter. You see here an EF about 35%, so moderately depressed with severe functional regurgitation. After a couple of clips, sort of trivial residual MR. Importantly, you can see here a rapid clinical improvement. I think we all love to focus on the kidney function as an important marker of clinical improvement. You see here over a period of about 4 days after the clipping procedure, creatinine went from 2.4 to 0.9. And importantly, seen in our heart failure clinic about 18 months later, continuing to do well, NYHA class 1 to 2 symptoms. And importantly, the GDMT could be optimized further after the mitral valve regurgitation was treated. And so I think that's another important point to understand, that treating the secondary MR does give even more opportunity for the titration of the GDMT. Now, In perhaps the most robust data that we have to support this kind of a procedure in that cardiogenic shock population. This was about 4,000 patients in the TVT registry, about a third of whom had secondary MR, about 14% had a mixed secondary and primary MR. You see here in those patients in the light blue bars who had a successful procedure compared to those in the orange that didn't, substantially improved mortality and heart failure readmissions out at 1 year. And so again, I think an important therapy for these patients. There is always sort of the patient that is unfortunately too far gone. So we do get a lot of referrals for patients with an EF of 15 to 20%, very dilated LV, moderate to severe MR, but really depressed cardiac index. And so in those settings, unfortunately, I think we've been referred the patient a little bit too late. So something to keep in mind for these patients you're following with LV dysfunction and MR. We know from these same trials of transcatheter edge-to-edge repair that when we don't achieve a good result, we leave people with moderate or significant MR despite the clipping. They're not going to do as well as you can see here in these curves. And so good news is that we do have some better therapies to offer in the contemporary era, and that's transcatheter mitral valve replacement. None of these are approved in the US or really anywhere, but we have access to a few of these devices, and I'll provide these to you just sort of as an atlas to understand that we can look at the anatomies of these patients in different ways, and hopefully we have a solution for them. This is an interesting device called the InnoValve, and what you see here, I don't think I have a pointer or a mouse, but these little C-shaped pieces of the ventricular part of the valve go into the ventricle, and we twist the valve to kind of hold on to the subvalvular apparatus. That's what keeps the valve in place. You can see here on the fluoroscopy, in a moment you're going to see just a little bit of a twist of that valve, as you might have seen there. What you're seeing on the echocardiogram here is, again, those little fans on the ventricular side engaged with the subvalvular apparatus of this patient's mitral valve. And once we deploy that valve into place, you can see here the valve is in place. There's no more mitral valve regurgitation there on the echo. This is another interesting valve called the M3 valve. What you see is the valve that's there surrounded by this scaffold. So what we do is we first put this scaffold into place. We're wrapping that around the subvalvular apparatus of the mitral valve. And once that scaffold is in place, we put this balloon expandable valve into it, thereby pushing aside the native mitral valve and leaving this transcatheter valve in place. And you see there, of course, the valve is just there. A lot of your patients are going to have not only mitral regurgitation, but also mitral valve stenosis. This is a patient with combination mitral valve disease. As you see there, a lot of mitral annular and leaflet calcium, a mean gradient across the mitral valve of 14 millimeters, significant mitral valve regurgitation, as you see there. Again, another transcatheter valve in place, and you see here no residual regurgitation, no residual mitral valve stenosis. So we can also treat combination valve disease with these transcatheter prostheses. This is a decidedly busy slide, not meant for you to even really look at, but just to simply demonstrate that the landscape of transcatheter mitral valve replacement devices is really large and getting bigger by the year. And so a lot of devices currently in trial, many, or I should say most of which, really are showing promising results. This is very near and dear to Dr. Starling's heart, no puns intended, and he's going to talk as well. This is an indirect coronary sinus annuloplasty. So the coronary sinus is very closely apposed to the posterior aspect of the mitral valve. This is a venogram of the coronary sinus. And we take this device, as you see at the top there, it's got two anchors. We place it in the coronary sinus, and we sort of cinch up the sinus. By doing that, we actually create an indirect annuloplasty. So this is where the sinus started, and at the end, that's where it ends up. You can see here in this patient on the left, the baseline mitral regurgitation, on the right, what we're left with after this indirect annuloplasty. This is a clinical trial device used as part of this trial called EMPOWER. The trial randomizes patients in a sham fashion 2-to-1 between receiving the Carillon and just continuing heart failure GDMT. A very important part of this trial is that once we randomize the patient, whether or not they get the device, down the road at 6 months, if they remain with severe MR and symptoms, they can be considered for alternative therapies, whether that's VAD, whether it's transplant, whether it's a MitraClip, whatever it is. So it doesn't really burn any bridges, if you will, in the treatment pathway for the patient. Another interesting part of this device is that it started out, this trial, as a mitral valve regurgitation trial. But with some interesting work that's been done sort of outside of the US, which Dr. Starling has been involved with, what they found was that in patients who didn't even really have significant regurgitation, but who had LV dysfunction and LV dilation, that doing this annuloplasty was actually beneficial with regard to LV remodeling. And so based on that, the trial actually took a little bit of a detour. So instead of becoming an MR trial, it really became an LV dysfunction dilation trial rather than MR. And so now we enroll any patients with a moderate degree of LV dilation, at least mild FMR, but that, again, not the primary reason to enroll these patients. And so, again, something to consider kind of in the, let's say, long-term or lifetime management of your patients with ventricular dysfunction. So this is always, of course, a multidisciplinary approach to secondary MR. In that patient with isolated secondary MR, we're looking at their GDMT, we're looking at any revascularization options that they may have. Of course, based on their QRS, are they a candidate for CRT? And AFib management is often a really important thing. Restoration of sinus rhythm, if it can be maintained, can often reduce mitral valve regurgitation. In those patients, after these sort of, let's say, a new set of 4 pillars perhaps is introduced, if there's a reduction in secondary MR to moderate or less, I think we should consider coronary sinus-based annuloplasty as part of that clinical trial. If they have continued severe regurgitation, again, we consider edge-to-edge repair, annuloplasty, or percutaneous mitral replacement. A lot of your patients may have had a prior mitral valve repair surgery. Unfortunately, as great as mitral valve repair surgery is in the secondary MR population, doesn't always have a very durable result. And so this is a patient who had a repair. You can see now recurrent significant mitral regurgitation. This is a patient we can also use clips for. We can't reclip everyone that's had a prior surgical repair, but it is possible in actually a number of patients to do it. Similarly, if they have an annuloplasty ring as part of their surgery, this is a patient with a very poor ejection fraction, prior bypass surgery and multi-valve surgery, who now presents, unfortunately, with mitral valve stenosis, as you see there. We can actually place a transcatheter aortic valve replacement into that mitral ring, as you see in the middle box, and then that replaces their mitral valve completely. So just to keep in mind that there are a number of percutaneous options that are available. These are all conscious sedation procedures, so even the concerns you may have about induction anesthesia, etc., aren't really an issue for these kind of cases. I'm going to close out just talking about tricuspid regurgitation, which we pay a lot more attention to in the contemporary era because of the percutaneous therapies that are available. So this is a woman, 83 years old, progressive fatigue and lower extremity swelling. There are a number of patients that I see actually daily with severe TR. They don't have abdominal girth, they don't have leg swelling, they just don't feel good. It's exertional fatigue, exertional shortness of breath, not the things that we typically attribute to tricuspid regurgitation, but very much is the reason for their functional decline. That's kind of what this lady had. You can see there the severe tricuspid regurgitation in the top right box. There's a clip sitting right above the area of her TR. Once we clasp those leaflets together, you can see they're kind of tied together in the bottom left box, and now there's no more tricuspid regurgitation. Great thing for this patient. And now see her 2 years after, it's now been about 2.5 years since her clipping. She feels better. She's on less diuretics. Her creatinine went from about the mid-1s range to about 0.9 because of less stress on her kidney. So kind of all good things. This is a Triluminate study, which is sort of the pivotal trial or seminal trial of tricuspid valve clipping in patients with severe TR. Again, a busy table 1, but the takeaways, average age around 78 years. Just around 60% in the trial were women. Nearly everybody had AFib because primarily these were secondary TR patients with AFib and enlarging atria. You see here, again, in a high or very high risk group of patients, an extraordinarily safe procedure, no emergency surgery, very low cardiovascular mortality, again, for high risk, very high risk group. And at 1 year, I should say at the starting, yellow, orange, and red means severe, massive, and torrential TR. So this is a TR they started with, and you see out at 1 year, 90% of patients had moderate or less TR. In patients, we tend to be at Cleveland Clinic, we tend to repair the tricuspid valve first if possible with clips. If it's not possible, there is also the commercially available option of the Evoke system where we actually replace the tricuspid valve. Again, this is a valve just sitting inside the ventricular aspect of the tricuspid. And once it's in place, that's just the valve in place. There is also, of course, good data here. This is the seminal trial of the Evoke called Trisend 2. Again, elderly patients, most of whom had AF, most of whom were functionally pretty badly off, as you can see there. And what you see is that out at 1 year, all of the patients essentially had either moderate or less TR. 95% had mild or less TR, so really a curative thing. There is a little bit more risk to this than there is for tricuspid valve clipping, and so we tend to reserve this for patients for whom the anatomy is not suitable to clip the valve. And again, excellent improvements in functional capacity, KCCQ scores, NYHA scores, 6-minute walk scores for this group. So in summary, contemporary imaging and devices, I would be remiss if I did not really give a kudos to our imaging colleagues. You saw phenomenal echocardiographic images there. We could not do the procedures we do without them. So contemporary imaging and devices allow us to fix, I think, pathologic states that were not previously possible with the same degree of efficacy. Next-gen devices for native mitral valve disease are currently under investigation and appear promising. Patients who've previously undergone cardiac surgery for mitral valve disease are often well-suited to transcatheter treatment. And percutaneous therapies for tricuspid valve regurgitation, I think, have brought a previously ignored disease sort of back into the light. So thanks very much for your time, your attention. Appreciate it.
Thank you, Dr. Krishnaswamy. We would like to ask the audience if you have any questions. Dr. Krishnaswamy will only be with us for this brief moment. Any questions from the audience?
Yes, Dave.
Yes, Dr. Byrne.
So very, very nice. So how do you sort out the patient with severe TR, maybe not torrential, but severe, but doesn't, with a little bit of SGLT2 and diuretic, no longer has ascites or edema? Because what you said was very interesting. A lot of people don't feel well, but do you do a VO2, or how do you decide? Because tricuspid clip is still not a trivial thing, I think.
So it's a great point, and to be very clear, we don't ever consider TR therapy or, frankly, secondary MR therapy until our heart failure colleagues give us the thumbs up that the GDMT is titrated as well as possible. Obviously, less literature behind what is the GDMT in severe TR, but certainly between diuretics, SGLT2 inhibitors, and as appropriate sort of HFpEF therapy is at least where we go. Beyond that, we're not really doing things like VO2 max or stuff like that. It tends to be more of a clinical conversation between us, in intervention, the heart failure team, and the patient. I think we don't exactly know what is the right time yet to intervene on TR, but we certainly know when it's gone for too long and the right ventricle is way too dilated and then the tricuspid valve is too far pulled apart and then we can't do anything. So there is that sweet spot there. I would say that as we have, as a community of interventionalists, have gained more experience with tricuspid valve therapy, as our imaging colleagues have gotten better with the imaging, it's actually an extraordinarily straightforward procedure when the anatomy is suitable. And that, I think, is reflected in the trial data I showed, where it's very, very low mortality and, very, very low even morbidity from a procedure like that.
None. Thank you, Dr. Krishnaswamy,
All right.
for
Thank
the
you, everyone.
opportunity.
Really appreciate it.
Our next speaker is Dr. Wilson Tang. He is the Research Director and Staff Cardiologist at the Section of Heart Failure and Cardiac Transplantation Medicine here at the Cleveland Clinic. He will be talking about novel therapies for cardiomyopathies.
Okay. You guys still awake? Good. So this is actually going to be the next few talk are going to be something more futuristic and also somewhat of a trials and tribulations and challenges that we face as we have a lot of people with GDMT, and yet there's still a lot of residual risk. So basically we have to find new ways, be creative, but most importantly to figure out how to beat the odds to actually show that this is actually effective and actually convince both patients, doctors, payers, and the FDA in particular that this is actually something that we should proceed. So that's always a challenge. I think the key here, as you heard throughout the day, is maybe it's a little bit too simplistic to think of HFpEF and HFrEF. There are actually good use cases of very specific, cardiomyopathies. Tomorrow you're going to hear very specific cases of amyloid and sarcoid and hypertrophic cardiomyopathy that has really innovative drugs. But I think the question is, what are the rest of the patients? And in fact, I think the key is to also look at what are the challenges of what is very, very important in other fields, particularly hematology, oncology, as opposed to gene therapy, cell therapy, and other forms of therapies, biologics. So, so to actually step back, I think a lot of times we actually kind of figure out why we are actually doing, what is the purpose, and how we actually go to treat heart failure, and what are the therapeutic targets. We could certainly assist and replace the heart, which is what we've done for a few decades. Repurpose some of the cells and trying to kind of direct them to kind of doing the good things and not the bad things is really the holy grail. In some ways, reprogramming. There's certainly ways for us to structurally change the configuration of the heart and all that. Many of them are percutaneous devices that we just heard of some. The tissue engineering aspects of it, which I'm not going to go into great detail, is quite promising. So I would actually, ask most of you to stay, ahead of the game in terms of looking out. There's actually cells that are making all the good stuff that we are extracting, potentially kind of an allogenic, autogenic way, autocrine ways to actually extract those materials for therapeutic use. So there is a really interesting area of investigation. Of course, the problem that we have is we actually know the mechanism, but clinically at the bedside, we have very difficult time characterizing those, measuring those. MRI, PET, they're not very sensitive or specific. So I think I think the molecular imaging part is going to help us a lot in the near future. If you think about it, if you have a nuclear imaging device that look at specific inflammatory cells that are there in pathologic states and actually after treatment it goes away, it gives us a lot of indication that this is actually helpful. So cardiomyopathy also has evolved quite a bit. Tomorrow you're going to hear more about it, but even this morning from Dr. Wilcoff's talk, we actually heard about genetic therapy, how we start to look at different forms of genetic variants and how they actually, direct our attention to actually different, downstream manifestations. And clearly there are more and more kind of ways for the computer to tell us the different types of disease. Still, the definition is as vague as it. A heterogeneous group of disease, even the definition started with the word heterogeneous, that's always a problem. That actually affects the heart, both in the primary and the secondary version. Now, some of them are genetic and some of them are not. And it's not because many of them are not genetically challenged in many ways. It's just that we don't know enough about the genetic underpinnings. It not be a single gene, it could be multiple genes, and it could be interaction between genes and the environment. And so there's still a lot to actually learn. In fact, our oncology colleagues have actually learned a lot about how cancer alterations and genetic underpinnings that actually are the drivers of disease, and this is what we are actually trying to follow. The second area is basically, even if you have certain condition, specific cardiomyopathy, I think the question is, who is the right person to actually intervene? I think the last question about tricuspid regurgitation is the same example. If you have the pathology, what's the sweet spot? Is it too early? Is it too late? Many times when we actually pick patients because of endpoint adjudication, we like them to be sicker, BNP is higher, We actually don't look at other biomarkers as mechanism biomarkers. There's actually a wave to think about anti-inflammatories, to actually use inflammatory biomarkers now. Cardiac MRI certainly tells us certain features, certain non-responding features like LGEs. So those are things that we have not incorporated. I think the last session that talks about HFpEF, we talked about the responding sweet spot. And so we haven't actually figured out who would be the right one for the right cardiomyopathies. This is actually something similar to what Jane presented. We have a lot more understanding of not just the alphabet soup of genetic cardiomyopathy, but also what all the genetic variants mean in terms of what the actual proteins are doing, but also in what location and what variant these genetic variants are actually manifesting. And one of the things that's very interesting is also the family history itself does tell us a lot. I think there was a discussion about somebody who's really old and actually still doing fine with the PLN. I could tell you that 1 out of 5 PLN dies suddenly too. I also have a patient who I remember exactly where it is. It's the parking lot of Target that I actually heard about him, had sudden death. So these are actually unexpected. And so ICD evaluation is obviously the common thing. But the key now is that we have genetic strategies that potentially mitigate it, both in terms of replacing the gene, altering the genetic architecture, but also things that are outside of genetic therapies. So of course the replacement is the most common. We actually have many of the gene therapies that are ongoing. I'm going to list out a lot in the next slide. The idea is very simple. Most of the genetic variants causes the pathology is caused by insufficient of the normal protein function. So the replacement really is using a virus to deliver that genetic component to restore the actual genetic function or the protein function by restoring the protein. Now, there's a limitation for that. Number one, you need the virus to go to the heart. If you actually inject most of the things, it goes to the liver. Okay, so that's actually one of the challenges to get the virus to the heart. AAV9 is usually the one that's being used. The second thing is we actually have to suppress the actions of a virus in the body. So we have to actually suppress the immune system so that we don't feel very sick. And so that's actually always a challenge, very much like what we do in transplant. We have to do the immunosuppression. But most importantly, in the gene replacement part, the actual protein and the actual gene has to be small enough to put in a virus. So that's why you have certain genetic variant that is being studied, because it's just small enough to be fit in the actual vector. This is actually the most common genetic therapy administration right now, and it's being tested in phase 1 and phase 2 studies. The gene silencing mode is a little bit more simple. It's really a dominant negative model where we are trying to suppress a protein that is potentially getting overexpressed or causing trouble. And that is actually can be done by any form of gene silencing, either an ASO or siRNA. These are actually transcriptomic suppression. And certainly the last but not least, which is actually quite interesting in its nature, is directly genome editing. They actually call it the molecular surgery. We're kind of altering the actual genetic code. And most of the time right now is actually whatever that can be directly accessible or actually in the liver. So that's what we see in FH, in familial hypercholesterolemia, and TTR, cardiomyopathy. That's actually mainly editing at the liver level. And this is truly changing the residue of the actual missense mutation or the variant. Now, it can also edit both the promoter region and different areas. So it's actually a lot more diverse in its potential. There's still a challenge in terms of the location. You want it to be organ specific. And in animal models, we certainly have done a lot of that in terms of specific targeting organs by tagging on with different organ specific expression. But still in humans, there's still a concern about off-target effects. So this is a busy slide, but it actually tells us at least the most direct way of looking at inherited cardiomyopathy in terms of technological advances and conceptual development, really coming down to guiding the specific protein that actually alters the chaperones or stabilizing proteins. That's actually, you'll hear a lot more about that tomorrow in amyloid, but also molecular targeting, particularly replacement. Now, the most advanced and actually FDA-approved versions has been the exon skipping for the Duchenne muscular dystrophy. You got young boys who are having very difficult because of muscle dystrophies, and there's got specific exon area that's abnormal that causes the destruction of the actual dystrophin protein that causes the muscle to be weak. The drugs actually ask the cells to skip an exon. So they got a truncated protein, but it's still working. And it's actually now there's at least 4 drugs that are FDA approved, and patients are actually getting it. Those are not technically gene therapy because it's not really replacing the gene, but it's certainly something that has been used clinically. Certainly there are many drugs, many genes that are now targeted for the gene therapy. Most of them are phase 1. Most of them are actually in the form of looking at whether providing the gene therapy produces the gene replacement that is intended. And so there have been a wide range of results. Most of them are still in the phase 1 era. There's some at phase 2, but there's also some challenges in some of these studies. Downstream, in terms of the actual secondary effects, there are certainly gene therapy that's not targeting genetic cardiomyopathies. Most of them are actually in the downstream region at the long non-coding RNA, as well as microRNA. These are epigenetic, alterations that target specific cardiomyopathies. And there's also small molecules that try to improve the cardiac contractility, not just the macavemtin type, which is the inhibitor, that's actually enhancers. And all these drugs are actually in early phase studies. So it's actually quite exciting that this is for the first time we actually have directly heart muscle specific therapeutic endeavors that actually try to modulate the fundamental problem, which is the myocardial problem. This slide really talks about the promises and challenges. Of course, great thing if we can precisionally targeting, very durable effects if we could alter the genetic underpinnings. There are opportunities for organ-specific delivery, and certainly is a disease-modifying therapy. Lots of challenge still in the delivery, in the off-target effects, and we actually don't know whether they are durable over time, in terms particularly when cells are changing. And then, of course, there's a huge amount of challenges in the cost and also the regulatory hurdles. About 4 days ago, the FDA actually has a roundtable, and in fact, all the companies are actually telling the FDA that it has been very challenging in getting, even non-cardiac, but any kind of cell and gene therapy to market because of all the hurdles in the development. So we actually do think, though, that this is going to stay because there are many diseases that are currently 40+ gene therapy that is FDA approved. Majority of them are hematology, oncology, and neurology, and some inherited eye problems. So clearly, we have worked out ways to actually provide some curative, disease management. And in fact, most of the time, we are going to encounter this even for patients without cardiovascular disease, but with cardiovascular manifestation, like sickle cell, like Duchenne's. We will be actually seeing them in our clinic for clearance, for evaluation, for appropriate patient selections. I suddenly have a lot of sickle cell patients in my clinic for that reason, because they're all getting evaluated for potential gene therapy. The longitudinal care is actually something that we are also going to start to manage. Immunosuppression is one of them. The phase 2 rocket study for Danon disease just got halted by the FDA because somebody died because of capillary leak syndrome. So these off-target effect, adverse effect continue to haunt our trials. And so there's still some things that we need to overcome. One very quick word on cell therapy. We had it for 20 years. We're still looking for ways to actually deliver the cells and actually to see some effects. There's some benefit in one of the biggest studies called DREAM Heart Failure, mainly using MSC cells. But clearly the challenges remain that the effects are modest, and certainly unlike science fiction, we haven't seen any repair or regrowth. Investigators have now turned to actually the secret sauce that perhaps the stem cells have. Neuregulin is one of them. We actually know it affects the heart and heart function, because when we give HER2 inhibitors, they actually do depress their heart function. And so we do have some ongoing studies. Dr. Agerman is one of the PIs. And so if there are any potential patients, please refer to us. So last but not least, targets for inflammatory disease we certainly have. We spent a little bit of time talking about it just now. Certainly, we knew about a lot of different inflammatory conditions, but we have not been pinpointing very well what are the processes. But what I would say is a lot of clinical studies on these biologics are ongoing. We heard about the IL-6 inhibitors and all that in the last talk, last series of talk. CAR T cells that has actually revolutionized oncology actually is being considered. At least there's some feasibility on antifibrotic effects. So they are being repurposed to try and attack the heart and try to improve, reduce fibrosis. We also have IL-14 inhibitors. They are immunotherapy agents that potentially cut the signal with the activated macrophages that may be helpful even for reducing arrhythmia or remodeling effects post-MI. So there are actually a lot of really exciting things in the immunotherapy realm for improving myocardial function and recovery. So in general, I think what can we do now and what can we look forward to? Cardiogenetic testing is one of the ways to facilitate precision medicine. And so I think as we continue to identify more cohorts of patients, we do get the opportunity to actually advance that area. This is a rare disease, but it's actually something that we probably have very innovative and potentially curative treatment. There are very promising development in gene therapy, even though there are lots of hurdles still. The regenerative area is still in challenge, although there are still studies that are ongoing to try and see if there are subsets that are helpful. And then new opportunities for immunology therapies probably is going to stay as well. Maybe potentially repurposing from our rheumatology colleagues and oncology colleagues. With that, thank you very much.
Thank you, Dr. Tan. Our next speaker is Dr. Nancy Albert. She's the Executive Director, Associate Chief Nursing Officer, Office of Nursing Research and Innovation here at Cleveland Clinic. She was a past and first nursing president of the Heart Failure Society of America from 2020 to 2021. She will be discussing lessons learned for diverse heart failure trial recruitment.
Thank you so much. Thrilled to be here today. So you can see I have one aim, and that is to discuss considerations for getting your trials recruited to meet sample size goals. So how big of a sample size is needed? Well, you may have seen slides like this before, bigger is better, but the right sample size is not a matter of preference. It needs to be based on an analysis plan to figure out the right sample based on beta, alpha, and effect size. And so what we really want to focus on is a representative sample. Now, for those of you who've been in heart failure for a while, you saw Dr. Estep's slides this morning, and he was showing us a lot of old studies. And I could tell you that in most of those old studies, the average age of the heart failure patient was 63.8 years. So think about how many patients you have that are in their 70s and 80s and maybe even their 90s, and that really don't meet that 63.8 years. The majority were males. We've done a better job of increasing females. The majority were white, Caucasians, not minorities that we see day in and day out. So a representative sample is really important to us. And so when we think about recruitment, the first thing we need to think about are what are the goals of the study? What are we really trying to achieve? And do we have the right power analysis that was completed to give us the representative sample and to give us the right number of patients? And then we have to remember about the leaky faucet. And you could see it here. You know, if you have in your mind, let me see if it pops up here, yeah. If you have 1,000 patients that you start with that you think are in your pool, you've got a big center, you may have a lot of patients that you're seeing day in and day out. You need to remember that when you pre-screen, you may lose about 69% of your sample. And so you're seeing that you're already down from 1,000 patients to 310. And then you've got the consent process and eligibility, and you lose more people that just don't want to be involved in research, right? They get a little nervous about it. So now you're down to 130. Then once you get through the consent process and you do more screening to make sure everything is a go, you find out that there's a few other things you find out about the patients that drop it again, so you lose another 32%. And by the time you figure out the dropouts and you get to your qualified patients, you may have 70 left. So we need to keep in mind that we need to think really carefully about how we're recruiting patients so that we can make sure we actually get to our goals of our research studies. We've seen quite a few research studies that stopped early. Now, during COVID, we had a kind of an excuse for stopping early, but we've seen other studies that have stopped early and then they never got the right hospitalization effect or the death effect or the combo of both of those outcomes as effects. And so we may have possible interventions that could have worked, that may have worked, but we'll never know because we just never got to where we needed to be. And I thought this was really important to remind everybody about. 85% of clinical trials fail to retain enough patients. So once you get the patients recruited, you want to get patients that you think are going to stick with it over time, right? Especially if you have a study. I have one right now. It's an international study, and we have to monitor and follow patients for 5 years. So once they get recruited, we have to figure out ways to keep them in the loop. And so that's really important as well. 80% fail to finish on time. 50% of sites only enroll one or no patients into their studies. And so we wonder why research is so expensive. If we can meet recruitment goals, instead of having 250 sites that only recruit 1 to 3 patients, we could probably have 100 sites and use that money more favorably to get the work done. 40% of trials in the U.S., at least the pharmaceutical clinical trial budget, goes toward recruitment. So a lot of money is going toward recruitment, and we need to figure out how we could do a better job. And then, as you saw on the previous slide, about 30% of patients may drop out of a clinical trial, especially if it's going on for a long time. So we need to think about that. So when it comes to recruitment, I want to show this slide first about the computerization. And for those of you that remember Dr. Martin this morning talking a little bit about AI and computers. So we have a study right now that's in process for amyloidosis where they use this beautiful AI system to get patients that were the right patients, and then many of them, or at least a few of them, enrolled in a trial. But it would have taken a lot longer to go through all of these medical records and do all of the qualitative lookup, because not everything shows up as an ICD-10 code. But imagine, if you will, down the road that you've got all the right ICD-10 codes for your inclusion and some of your exclusion criteria, so that we could pull now just by using e-research analysts, but then you use AI to have all the right qualitative descriptors, and down the road you really get a good sense of the patients that may meet recruitment. So today we have a lot of ICD-10 codes we use. We have e-research team people we ask to pull data for us, but we still have to do a lot of chart review. So what it means for me when I'm recruiting and when I'm using my research coordinators is I need to make sure they really understand all of the things to look for, but that they don't sit in the chart for an hour per patient, because then I'm spending a lot of money on recruitment again and getting off track. So there's this balance of getting the right patients, but not spending hours and hours on each one to figure out who are the right patients for inclusion and exclusion. When we think about flexible recruitment options, we've got a lot of opportunities with us today that we didn't have years ago. We have started doing a lot of telephone recruitment. We started it during COVID. During COVID, we had a study. Within 4 months, we recruited over 1,200 patients, mostly by telephone and a few by mail. The patients from mail we called up to finish the recruitment process. And then we started using DocuSign to do the informed consent. So we got to keep in mind, if you're not at Cleveland Clinic and you're someplace else, talk to your leadership teams about getting the right tools in place so that you can make recruitment a lot easier for yourself. We do a lot of video teleconferencing. Some patients want to see you. They don't want some distant person they've never heard of before, they've never seen before. They don't recognize your name. As you well know, a lot of patients don't answer their phones these days because of spam. So we've got to figure out how to make this all work. We do mail out a lot of materials. We use MyChart. So for those of you that have a Epic or a different EMR system that allows you to send a blast email to a bunch of patients who you think meet the criteria, and the patients can respond. So the first thing we do is take all of the yes patients and try to get them recruited right away, and then we deal with the people who didn't respond at all and call them up. So again, you've got to plan ahead a little bit for potential recruitment and retention changes that may happen. I have a study right now, this big international study where I have to get 1,000 patients enrolled. And these are people without heart failure but are at high risk for heart failure. And so what we decided to do, we just went back to our IRB and we said, you know, all the patients have to be is over 40, and there's a bunch of inclusion criteria. We have a lot of employees who are over 40. Maybe we could get employees to be recruited as potential subjects for this trial based on the inclusion and exclusion criteria. So we just are waiting for a flyer to be finished getting IRB approved, and we may put it by some of the time clocks where our employees clock in and clock out, and to find out if they may be interested in being involved in a research study. Our neuro team did it for a big study called the Brain Study, and it was very effective. At least 5 of my team members joined that study just by seeing a flyer posted somewhere. So we just need to keep in mind where we want to get patients from, and do our supposed patients in this or participants in the research meet their criteria for being involved. We also need to remember that we have to plan for people who are away from work. So I had a nurse, a research coordinator who was out for a month because of a surgical procedure and recovery. You have coordinators who are out for vacation, and you don't want to have all those gaps because somebody is waiting for you to recruit and enroll patients and get them into the study, especially if it's a funded study. So how are you going to overcome some of those nuances? So when we think about test recruitment strategies, we need to think about, are our strategies realistic? Do they ensure strong communication with participants, stakeholders, which could be many people? We've all heard the saying, out of sight, out of mind, right? And so I'm a heart failure advanced practice provider. I'm down in the clinic at least 2 days a month seeing patients, but I have no idea of when a new research study in the heart failure world is started recruiting, because I don't see anything in front of me. So it's out of mind for me. If our research team started sending us updates once a month, or put a laminated sheet by the computer in the different clinics, maybe I would know about research studies. And I have patients that I'm guessing would be very willing to say yes if it was a research study that was exciting to them. So for those of you trying to recruit, think about how you can make sure you're not out of sight and out of mind for the people that you want to think about bringing patients or whatever the participants in. So use multiple strategies and understand and incorporate individuals' cultural traditions, beliefs, etc. So again, we need to think about individuals as individuals and make sure that we're planning for that when we're figuring out how we're going to go about with recruitment. So I know this may sound like a very simplistic picture here, but when you go into a room, if it's a hospital-based patients, and I find them the easiest to enroll because they're a captive audience in a room and they may be a little bit bored. So as long as you don't catch them during a meal, because meals are very important, we never interrupt those meals, usually we can talk to patients and get them to be enrolled in a study. But when you do meet patients face-to-face, whether it's in a clinic or a waiting room or in the hospital, make sure you maintain eye contact, you have really good facial expressions, you look like you care about your job and you're really interested in your job, because patients will get those subjective and objective cues and may decide not to participate just because of something you say or your mannerisms when you walk into the environment. And then again, think about recruiters with different functions. I have some nurses on my team that are research coordinators that love doing EMR work. And then I've got one other person that loves to go up on a unit and individually talk to patients. She wants to be around people. So we try to divvy up the work whenever we can, because then we're going to get the best productivity out of our employees. And again, that will help with recruitment and retention. And it'll also help you getting the diversity you need, because the people that are doing it know exactly what the goals are. And again, think about awareness of the study within your facility. So again, when you're doing recruitment and planning, think about the planning phase and think about the conduct phase. For me, we have huddles once a week. We talk about recruitment goals. I ask my team every Friday or the last day they work, because they're part-time, to give me how many patients they got inclusion on, how many patients that they approached, how many patients that they actually recruited. And so it forces us all to be honest about where we're at. And I have found that to be really valuable in actually getting numbers up really quickly when you make everybody accountable for what is actually needing to be done. All right, so I just, before I leave, want to make sure I talk about language. So we need to think about what we say to our patients. We all know that the typical informed consent form, the written informed consent, has a lot of 4- and 5-syllable words. And I'm just not talking about a drug name, but I'm talking about, just the way it's written. And so oftentimes our patients may not understand what it is that we're asking of them. And so I try not to use the word experiment. We try to talk about a study. Most people understand the word study. We never ask them to be subjects. We ask them to be participants. It sounds like a simple thing, but to a patient or even a nurse or somebody, whoever your subjects are, that could be very important to them. And then let them know about the goals of the study and why it could be important to them, even though there may not be direct benefits to them. People are altruistic by nature, and if you tell them what the goals are and how this may help people down the road, even if it doesn't help them, they may be more likely to say yes and join your study. All right, so I'll just leave you with these 3 slides here. This first one is willingness is a function of recruitment. And if you look above the black line, you see all the different factors that play into force. Awareness and appreciation, education, expectations, environment, credibility, relationships, responsiveness, resources, and communication. And then below the line, you see what could get us into trouble, the risks of the study, especially if there's a lot of risks. You have to talk about those risks to give full disclosure. But we also have to think about the inconveniences to our patients and what we're doing. We always try to give them free parking. Depending on how much time they're going to spend here, we may give them a meal voucher. So you need to think about ways you could help recruit your patients and keep them engaged and interactive. So on this slide here, you can see the clinical research coordinator and the PI who usually has to deal with the different various aspects here. And you've got to think about what levers you're going to push to really help with recruitment and retention over time. The last thing I'll just mention is you've got to share what your goals are with everybody on the team and also share where you're at with your goals. I love the old temperature thermometer. So in nursing, when we have goals, we actually ask the nurses to post on a unit what the goal is, what 100% looks like, and then we show the little red bar of where we're at. And once a month, we may update it because, again, out of sight, out of mind. So if you're trying to recruit people into a study, they could see, oh my God, they only need 15 more patients. I didn't participate. Maybe now I'll participate, depending again on who your subjects are. So my key takeaways are really there's no cookbook to strategies. Each study needs to be tailored based on what your inclusion and exclusion criteria are, the potential participants, who the investigators are, what the expectations are based on who's leading the trial, and if you're one site of a multi-center study or if it's your single center study at your site. And be prepared in advance of startup. Regular team meetings and weekly goals can be really important to getting to your goal quicker, and request coordinator updates. So with that, I'll stop. Thank you very much.
Thank you, Dr. Albert. Our next speaker is Dr. Randall Starling. He is a staff cardiologist in the section of heart failure and cardiac transplantation medicine. He was a past president of the Heart Failure Society of America from 2018 to 2019. He will be talking about the next generation of HFrEF therapies.
Thank you, Ariane. And for those of you that know me, my voice is under a little bit of distress, but I will do the best I can. I want to thank Dr. Vest for organizing this and giving me the opportunity to share a few of my thoughts with you. I really enjoyed Dr. Albert's presentation, and the title of this subsection is Hearing from the Trialists. So research is very hard work. You put a lot of work in, and return on investment, if you have a positive trial, is great, and if you have a negative trial, it's extraordinarily disappointing. So I want to take a couple minutes just to set the stage, to give you some bias, if you will, about the structure and what goes on behind the scenes before I share with you a handful of clinical trials that I want you to keep an eye on over the next 5 years. So if you look historically at clinical trials, it was kind of a mess as far as definitions. Some would say we'll take patients with ejection fractions of 35% or less. Some would say 45%. Some would say 50%. So a couple years back, this group that included the Heart Failure Society of America, the ESC, the Japanese Heart Failure Society, many stakeholders got together and said, we're going to come up with some definitions that we think make sense. Since that happened, that's pretty much been adopted by the American Heart Association and the American College of Cardiology. So my assignment is heart failure with reduced ejection fraction. So I'm going to focus on some studies where the ejection fraction was less than or equal to 40%. So just to hammer that point home, sacubitril valsartan, we started doing clinical trials with this drug in 2014. Lack of standardization in the past and regulatory approval as far as the package label, it relates to the clinical trial. So if you do a clinical trial, which the Paradigm HF that said patients have an ejection fraction less than or equal to 40%, you really can't extrapolate to an ejection fraction of 45%. So, and that's how regulatory looks at this. So this trial was a huge success, and then they came along with Paragon. Why did they choose 45%? I can't answer that question for you, but that today doesn't fall into any conventional definition. It's right in the middle of heart failure with mildly reduced ejection fraction. So understandably, and I was involved with the Paraglide study, guess what we did? We had to fill a gap. So Paraglide, the enrollment started at greater than or equal to 40%. So when the FDA gave a widespread approval of sacubitril valsartan, which they didn't give a number. They said less than a normal ejection fraction. Okay, so the other body that I want you to be aware of is called the Heart Failure Collaboratory. And the Heart Failure Collaboratory worked with an expert panel that included the FDA, the NIH, international experts, and there are now published guidelines, if you will, for clinical trials, for endpoints, and as you heard from Dr. Albert, sample size relates to endpoints and the effect of whatever you're studying. So these are all very, very important things that you don't necessarily realize when a drug is approved, but a lot goes on behind the scenes. So I'm going to mention 3 types of clinical trials, basically. Pharmacologic, which is what everybody, I think, is most familiar with. Device studies, which is an expanding area. And what about implementation? I want to make sure that I get across the point that implementation science aims to improve the use and adherence of medical therapies. So if I asked anyone in this room, is sacubitril valsartan a good drug? I think everybody would raise their hand and say it's a fantastic drug. But the realization that guidelines require effective translation to become to reality. So here is reality. And this is from the Evolution HF observational study. And the bottom line is, if you look at the 4 pillars of guideline-directed medical therapy for HFrEF, we don't do a very good job in the US, and that is true around the world. So one slide just to mention an effort that the Cleveland Clinic has been involved with the Heart Failure Society of America. Dr. Martin may have mentioned this. I'm sorry I wasn't here this morning, but this is an educational effort. It's a simple module, and we have a pilot program at the Cleveland Clinic where physicians, nurse practitioners, pharmacists can take this course to improve their knowledge of implementing guideline-directed medical therapy. So I'm sure that Dr. Bhattacharya probably talked to you about shunt therapy. So I'm going to focus on shunt therapy in heart failure with reduced ejection fraction. So I'm sure you know the concept from the earlier discussion: pulmonary congestion, pulmonary edema. What can we do to lower left atrial pressure? And it's been shown in humans as well as in simulation that if you create a shunt in the right patient situation, meaning higher left atrial pressure than right atrial pressure, you can reduce the pressure when you create a shunt. So now comes the devil in the details, so to speak. So there's a lot of activity in this space, and it relates to size and shape of devices. What is the diameter of the orifice, the opening that is created? And on the right-hand side, you see an active clinical trial that you probably heard about this morning called ALAY-HF, where a hole is cut. So tissue is removed, nothing is put in, and the company that is involved in this secured, I think, in the range of $90 million in venture funding, and they're going to be launching a study in heart failure with reduced ejection fraction. So you may wonder, why would they want to do that? And this slide is going to demonstrate how this all happened. So a number of years ago, this company out of Southern California developed this V-Wave shunt, And they, unlike the Corvia that you heard about this morning, I'm sure, and the responder HF, they said, we're going to take heart failure patients. We don't care what their ejection fraction is. It can be low, it can be normal, and we're going to test this hypothesis as to what does a shunt do. So this is now published in Circulation. Rumor has it that they've gone to the FDA, or they're planning to. I know there was a meeting planned that apparently got canceled, but this therapy could be coming soon, or maybe not. But here's what's really ironic. They pre-specified to look at less than 40% and greater than 40%. What they found was that in the greater than 40%, the therapy appeared to be dangerous. It did not have good outcomes. And in this slide, the red line is the shunt group, which had fewer events. So they won in the reduced ejection fraction, which is probably why the Alleviant group is now going to launch another study to look at heart failure with reduced ejection fraction. But there's a caveat here that I want to put out there, which is the Kansas City cardiomyopathy data. So everyone knows about patient-reported outcomes. There's heart outcomes, survival, hospitalizations, events, and then there's patient-reported or quality of life. So this was a little bit touchy here, where very dramatic reduction in events, but absolutely no difference in the Kansas City cardiomyopathy with this particular therapy. So it'll be very interesting to see what unfolds. So next I want to shift to a medication, omecamtiv mecarbil. How many in the room are familiar with this drug? Just raise your hand. So most of you are familiar with this. So there was a New England Journal publication that looked at this particular drug. It's known as a calcium sensitizer. It specifically is not considered to be an inotropic agent. It increases the force of contraction. So the primary study that was done was called Galactic HF. The hazard ratio for that study was 0.92 with a p-value of 0.03. This one, I think, is fact. It has not been approved. It's been reviewed by the FDA. So the company, Cytogenetics, has launched a new clinical trial, which we are participating in at the Cleveland Clinic. It's called Comet HF. So they were very smart, and we participated in Galactic HF. So they made pre-specified hypotheses related to the effect of the drug depending on the ejection fraction. And what you see here is the effect size appeared to be greater in those with low ejection fraction. And this is from Galactic HF. And here you see the patients with ejection fractions less than 30% with a hazard ratio of 0.85 and a very significant p-value. So that's the background data. So what is the design of this particular trial? So everyone has heard of ACC stage A, B, C, D. So some of you may be familiar with the label of C to D. What does that mean? So the thought process is stage C, patient's doing good. Stage D, real patient needs an LVAD. There's a bunch of patients in between. They don't need an LVAD, they have symptoms, maybe they got hospitalized. So that's this so-called ambulatory C to D. I think Dr. Yancey at Northwestern may be one of the first that wrote a paper about this. So they want to capture patients with heart failure with reduced ejection fraction. Many have been hospitalized. There's a subdivision based upon whether the patient has atrial fibrillation or not. And I want to point out, in GALACTIC, they did not see more atrial fibrillation in the patients who received the drug. And the other very curious observation was there was less stroke in the patients that received omecamtiv mecarbil. That is going to be watched very, very closely. So this will be an event-driven trial. The primary endpoint is pretty typical: cardiovascular death, heart failure event, stroke, LVAD, transplantation. So we're very excited about this trial and hope to begin enrolling soon, and hopefully all of you will have patience. So I just couldn't resist putting this one slide in just to acknowledge, and I have the opportunity to work with Dr. Vest with the ASTRID-HF study. You didn't share this morning, did you? So this is also a HFrEF study. This is Dr. Vest's homegrown study that she has an NIH grant for. So what is this study about? So we know that patients with heart failure can get sarcopenia, they can get cachexia, they can get protein calorie malnutrition. So this is a pretty simple study to get patients with EFs less than 40 that have elevated BNP. They've been admitted to the hospital. There's a number of different criteria. They will have specific testing to look at skeletal muscle mass. It goes over 6 months. It's randomized, controlled. So again, this is a study you may think about referring a patient to us. So I'm going to show you one slide just to create a thematic discussion for you, and that is the concept of LV remodeling. If you look historically, there was a time when surgeons cut a piece of heart muscle out and very dramatically and instantly made the heart smaller. There was a stitch study where the surgeons in a post-infarct patient removed muscle. There have since been a number of techniques, parachute, myosplint, different things to try to reduce the volume of the left ventricle. So we're participating in the AccuSense trial. Dr. Yorday from New York, who was just visiting us recently, is one of the principal investigators on this. So this is a catheter-based interventional cardiology combined with a heart failure specialist to put this device in to reduce the size of the left ventricle. So greater than 20%, less than 40%. So all of the studies that fall into this kind of grouping, we don't want a ventricle that's too big, we don't want a ventricle that's too small, we don't want an ejection fraction that's 10%. So there's kind of a sweet spot similar to what you heard about with the MitraClip. So the last drug study that I want to mention, which this is not a HFrEF study that I have up here. This is the Fine Arts study, which was with finerenone. So that is a non-steroidal mineralocorticoid receptor antagonist, published in the New England Journal. Very positive study. And the bottom line in the conclusion section says, we cannot conclude that this is a class effect, meaning this doesn't mean spironolactone would do the same thing, or eplerenone for that matter. So the reason why I'm mentioning this is there will be more studies done with this drug and drugs in this class. So at the bottom of this slide, a randomized double-blind placebo-controlled pragmatic study to evaluate finerenone in patients with heart failure and reduced ejection fraction. The finality heart failure study is underway. And just to make a couple simple points here, these drugs are different. So they have different potencies, they have different affinities, whether it's for the kidney or whether it's for the heart, different half-life, different effects on quote-unquote sexual side effects and blood pressure. And what is very intriguing to me is what's happening now, and this is balanced HF, which Duke is involved with. They're just in the process of launching this study, which is yet another non-steroidal MRA, valsartan, but it's being used in combination with dapagliflozin. So use your imagination what some of the marketing people behind the scenes may have thought about to come up with this. And guess what? There's also a whole series of studies being done with a combination of finerenone and empagliflozin. So I think we're going to be seeing a good bit of this evolving over the next 5 years. So I need to finish up here. So the other concept I want to mention to you, which I think is extremely important that falls into this space, has to do with defibrillators and modern guideline-directed medical therapy. So we are still using in the United States data that was generated from the SCUD-HAV study and trials that were done many, many years ago. So if you focus on the bottom left-hand panel and you move from left to right, you see the added benefit that has been observed as new medications have come into the scene. So if you look at all-cause mortality that is shown in light blue here, it is pretty close to the red bar, which is 4-pillar GDMT plus the defibrillator. And the same thing is shown with sudden death. So this has created a huge amount of discussion around, are we using too many defibrillators? Now, just a couple points here. If you look at patients that get defibrillators, you can risk stratify and predict who's going to get a shock, who's not going to get a shock. Probably all of you have had patients that have had a defibrillator for 10 years that have never had a shock. So the MADIT ICD benefit score, here's the punchline. So this study will be launching everywhere. It's called Contempt. And Dr. Sheesh is on the leadership. She's the site PI. This is going to be a pretty simple study. If a patient meets a current ICD indication and they get a MADIT ICD benefit score that falls into a low-risk category, they're going to get randomized to an ICD versus no ICD, all-cause mortality, death from any cause. So Dr. Krishnaswamy and I compared notes, so I knew he was going to talk about Empower because he told me he was, but I said, okay, well, I'm only going to show one slide from a different perspective. So this little device you see here goes in the coronary sinus. Dr. Krishnaswamy showed that to you. It's a simple interventional procedure. Why are we excited about it as heart failure doctors? So if you have a patient with mild mitral regurgitation, you have them on the best GDMT, but they come to the office visit and say, I'm still short of breath. I can't do all the things I want to do. That patient may be a candidate for this particular study. It's been shown, and it's published, that putting this device in the coronary sinus can reduce the ventricular size, the volumes, and attenuate mitral regurgitation. This is commercially available in Europe. It's CE marked. It's in wide use. But this is an important clinical trial that Dr. Kapadia and I are involved with here in the United States. And as you can see, the device facilitates coaptation, reduces mitral regurgitation, and the volumes improve. So thank you very much for giving me the opportunity to share some of this information with you. Thank you.
Thank you, Dr. Starling. Now we open the floor for questions from the audience. You can also post your questions online for people who are doing live stream for this conference. Oh, Dr. Hanna.
Yeah, so that was a great session. I'm going to ask a question to the group that we may not know the answer to, but you know, we have people who improve their ejection fraction to normal on guideline-directed therapy. And on all four pillars, you know, one of the questions is, do you continue all four pillars, or can you, for example, liberate them from the MRA or SGLT2 and leave them on an ARNI and a beta blocker? What are your thoughts on that?
Is this on? Yes. Okay. So we all have an opinion on this. I'll give you mine. So the conventional dogma is you never stop GDMT. That's the conventional dogma. That is being challenged recently. And I just saw this very, very recently. Somebody did a study, asked the exact question that Dr. Hanna raised, and they hypothesized that the most important pillar was the beta blocker. So I think they did a randomized study, and one group went to carvedilol alone, and they were stable. So my own bias is I try myself to keep the patient on ARNI and the beta blocker. I have a lower threshold to peel away the SGLT2 inhibitor if the patient's even on it, or the MRA, which also begs the question, what do I do when a patient I've followed for 20 years who's normalized their ejection fraction for the last 15 walks in and they're on lisinopril and metoprolol? Should I add an SGLT2 and MRA on top of it? That's the question.
All right, so I agree. I would, in general, I would leave them on their therapy only because I've seen multiple patients from other sites come back to us because they weren't local, and another provider took them off of their medications, and suddenly their EF went from 45% to 20%, and it was much harder to get them back up to, not harder to get them back on therapy, but harder to get rid of their symptoms the second time around. So I've learned that not to tempt fate there. However, as patients get older, we see that they don't always tolerate the therapy. So I do have some patients that I've been seeing for over 15 years now, and I've noticed I've had to back off on the MRA and oftentimes on the beta blocker. So I don't discontinue it, but I will definitely decrease the dose. I may have to cut it in half and even in half again, depending on how well they're doing. And it's usually hypotension and sometimes chronic kidney disease that gets them into bigger trouble.
I think what Dr. Starling mentioned is the Cathedral study that was just published this week in JACC. That's actually people got rhythm controlled after AFib. So they have a drop in EF, they actually got, so there are some patients that obviously, like if you, and also with the CRT responders, that's the same. Wilfred Mullins actually did the study where they actually withdraw almost all the drugs. The reason why people went back is because of their blood pressure and also AFib or whatnot. One thing that's actually quite intriguing is we worship LVEF, and we do not actually think beyond other features that potentially give us information. I think I put a slide in terms of biomarkers and also MRI that actually give us a lot more tissue characterization. One very intriguing insight, and we actually saw it in our cohort here at the Cleveland Clinic, it's only 1 out of 8 patients who have serial echoes and BNP, that even if, although all the people who completely recovered, meaning the LVEF is 50 or above, only 1 out of 8 people have a normalized BNP. So that may explain why a lot of people do relapse. We also have seen a lot of patients that despite GDMT also relapse. So I think we may rethink about how we follow our patients. Obviously, when somebody presents with a low EF, they're already in the category for HFrEF. But if you think about it, most of the GDMT these days really is rely on an elevated BNP as an inclusion criteria. You know, SGLT2, MRAs, even Paradigm, if you think about it. So I do think that if somebody recovered the EF, I would maximize the therapy to go for the minimum amount of anti-BNP. That's actually my approach. And of course, if there are symptoms, I would definitely not stop. You know, obviously, some people, despite their EF improve, they actually still have some symptoms. Certainly, still some physiologic alteration. Now, the question is, just like the HFpEF, question we have, is the symptoms related to the cardiac pathology? Is what we have to look into.
I will also mention the BNP story. I think is very, very interesting. So we know that sacubitril valsartan may have a different mechanism, if you will, as far as BNP lowering is concerned. Having said that, having followed many, many patients serially as I'm titrating GDMT, I systematically follow N-terminal BNPs. So I can't get echoes as frequently as I get N-terminal BNPs, but so what have I seen? BNPs 4,000, then it's 1,000, then it's 500, now it's 50. I get excited. I can't wait to see the echo. Sometimes it's really good, sometimes it's not. So I don't think there's a one-to-one correlation there, but Dr. Tang can probably tell me, because I don't know. I'm sure that patient's prognosis is better because they have a low BNP. So my rule of thumb in clinic, which is based upon some of the trials that were done based on BNP, I tell patients, my goal is to get your BNP under 1,000. And that's very generous. If I can get it under 500, then I'm really happy. And one thing I failed to mention during my presentation, so that balance, heart failure, which is the combination of valsartan, there's no ejection fraction criteria. They're taking all comers. So that's the other thing that I think we're going to see potentially more and more of, is treating the heart failure and not focusing on the ejection fraction per se. Because the ejection fraction is a moving target. It goes all over the place, depending on how you measure it.
Thank you. Dr. Finney.
Yeah, so it's wonderful to have two Cleveland Clinic faculty who are also former presidents of the Heart Failure Society of America sitting side by side. My question is, how is the society, or how can the society influence research in the heart failure arena across the centers in the United States in the future? What has been the vision and the strategies to accomplish that?
You're a more recent president than me.
So the society does have a research group. I haven't seen in the last year what's going on with it, so I'm going to find out soon when the meeting comes up this year. It was canceled last year, as you well know, because of hurricanes. But the goal initially from the research standpoint was to get contributions and to try to help connect different centers with studies that were up and running by mostly industry-sponsored studies so that we could get data faster and get to analysis and get to new treatments. The other thing going on is the society has a philanthropy type program where they're asking us as members and former presidents, et cetera, to give money toward the organization. And some of that money is really aimed at being used for individual research by people who apply for grants. So I'm hoping to start seeing grant requests come up through emails so that we can actually see the benefit of us giving money toward that organization.
So that's a good summary, and I'll just elaborate. So the research committee, they're about ready to launch a trial, a study. I think it's called Reimagine HF, which I'm pretty sure is a genetic type study to do genetic testing. Maybe Dr. Tang can elaborate. And yes, they are funding individuals with modest amounts of money to do research. And as far as the philanthropy and the research foundation, I'm on that committee. And Heart Failure Society of America, they made the executive decision that they were not going to go to industry to solicit funding. They wanted to develop a grassroots effort from the membership. So I think they're on track for their targets as far as raising funds, but this is a whole new venture for the Heart Failure Society of America. So they're very early into it. They had research studies 10 or 15 years ago. One of Dr. Tang's former mentees, I think, was funded. But they're actively trying to get back into that business.
Yes, the Reimagine, I actually forgot to mention it. It was actually in one of the slides. Really trying to press, particularly in rare diseases, where there are so few people with genetic cardiomyopathy, so they actually try to build a consortium. And there's actually a new era in terms of it's actually following many of the patient support programs. I think cystic fibrosis is one of that we actually emulate. They actually ended up collaborating with different industry who are actually having the same problem to find patients who have genetic cardiomyopathies. But then if the Heart Failure Society membership actually have identified those patients, potentially there is a possibility of collaborating with industry to actually help enroll these patients. So I think this is kind of a new era, particularly in terms of decentralized clinical trials for heart failure clinicians as stewardships as well as promoters of clinical trial enrollment and all that. And I think it'll be interesting to see how it evolves, but there is a commitment from the HFSA to actually try and promote that.
Thank you. Any other questions from the audience? If not, thank you to our speakers for wonderful talks.